So number one is yes, cross-link at diagnosis, and number two is no cross-link only when we see progression.
It's 50-50, eh?
This is going to be the second referendum. It's going to be 57% Remain. Okay, so we're all right.
So, Bruce, you can step up on the podium to support on yes, on Brexit.
So, I'm going to support cross-linking a diagnosis, but maybe not for everybody, okay? So there's a bit of balance here to this debate, unlike our parliament at the moment where there's no balance at all, okay? So the first thing to say is cross-linking is not risk-free. That's one problem with it. Here's some complications, melts, infections, scars, they can all occur. And 1 patient in 30 loses some vision after cross-linking. Second problem with cross-linking, we talked about it this morning, we don't know if we are inducing some kind of progressive flattening syndrome that never stabilizes the corneal shape after cross-linking. We may not find out for some years. So, you may think, well, why do we cross-link anybody at all? Well, what we don't want is a corneal transplant afterwards. This is a scenario that will be familiar to many of you. This is a rejecting transplant. If you look at the statistics for corneal transplants, if you have a first graft fail, your second graft is more likely to fail, and we are grafting people in their 20s if they go wrong with keratoconus. So we don't want them to go down the grafting track if we can avoid it. And even if we do DALC, if you look at the registry studies, then the results are not much better. So we want to avoid corneal grafts. And so one way we can do that is we can try and improve the vision, and we can also try and stabilize the cornea. But the question is, should we do it right away or should we wait until we see progression? Should we wait for people to get bad enough to need the laser treatment as well, or should we try and anticipate that? So the model we are running with in the UK at the moment is this, that we have a specialized clinic, and we have our optometrists screening the patients. They're refracting, they're looking at the corneal shape, corneal tomography. And they're using a set of numbers, and we define how big a change we want to see to say progression has occurred. And then if we see that change after diagnosis, we go to epithelium off, cross-linking down the bottom here, and then we continue monitoring until we see no progression, or for a maximum of 5 years. That's what we're doing now. Because our NICE guidelines say that we shouldn't be cross-linking unless we see progression. But then there's the danger that we lose vision. So why wait for that? And many anxious parents present you with their children. They don't want to wait for the vision to be deteriorating before they have something done about it. So we know who is going to progress already. We know that young age is a risk factor of progression. We know that non-white European ethnicity, that's a risk factor. And also advanced disease in the other eye. If you've already got bad keratoconus in one eye, you don't want to wait for progression in the other eye. So these are patients we maybe do want to cross-link at diagnosis, the young patients, that high-risk patients. What about just telling people not to rub their eyes? Is that going to be enough? We don't know, but I mean, that may help at least. What about epithelium on cross-linking? Remember that first slide I showed you here? Let's just quickly go back to that. So we don't want to see this, right? So if we get a way of doing cross-linking without taking the epithelium off, almost all the complications, infection, antigen deposition leading to inflammation and melt, all those things relate to removal of the epithelium. They're complications relating to removing the epithelium. So if we can do cross-linking effectively with the epithelium on, then the dynamic changes, right? Also, we don't have to worry about giving the patients a painful week if we're leaving the epithelium on, but the treatment's got to work. The good news is that modalities for epithelium on cross-linking are really making progress now. There's good in vitro evidence that we can get a good stromal soak with riboflavin compositions, and there are some tricks that are used to modify the delivery of riboflavin. First of all, we wipe off the mucus layer with sponges. That helps absorption. We use riboflavin compounds that have agents that help penetration. Hopefully they're not so toxic that the epithelium falls off anyway after treatment. After we've applied the stromal soak, we irrigate briefly to wash the riboflavin out of the epithelium. Otherwise, you just give a patient a welder's eye, arc eye, by doing the UV light exposure. We don't want that. So we've learned that we irrigate the riboflavin out of the epithelium. And lastly, and most interestingly, hyperoxygenated localized environment, goggles to produce a hyperoxygenating environment that increases cross-linking efficacy. And if you do those things, it looks now, we'll find out definitively in 2 or 3 years after the trials have been done, it looks now like epithelium on techniques are catching up to epithelium off for efficacy. And so question I've got to ask you is can we replace this scenario where we're just cross-linking when the patient has progressed with epithelium on cross-linking at diagnosis, then going into our monitoring algorithm, and then saving the epithelium off treatment, which is the higher risk, painful treatment for cases that do progress. So what am I advocating? I'm saying, yes, let's do epithelium as on cross-linking at diagnosis. We need epithelium on treatments that work to make this work, and we need community screening to pick up patients in their mid-teens, so before they lose any vision. And we need treatment. This epithelium on treatment can't be £2,000 or €3,000 a case. It's got to be something that people can afford and healthcare systems can afford. So if you can satisfy those 3 criteria, you've got effective community screening. Well, the optoms have already got corneal tomography. If you've got an epithelium on treatment that works, I think we're almost there. And if you've got that treatment delivered at the right cost, we've got to work on that, then I think that you can make the case for treating cross-linking at diagnosis rather than waiting for progression. Right now, do I think we should apply treatment at diagnosis selectively? Yes, for high-risk patients. Do I think we should do it in everyone? No. So it's a little bit of a balanced message there. Thanks very much.